All right, well, it is 11:45, Whitney, and I see that the numbers are, and we very well may have guys into the first 5 minutes or so, we'll probably see that number continue to creep up. But in order to keep everybody on time, I'm going to go ahead and turn it over to you, Whitney, and take it away.
Thank you, Danielle. Good morning, everyone. I hope that you all have enjoyed the previous sessions today and just the Launch into Telehealth virtual conference overall happening over the past few Fridays. My name is Whitney Wiggins, and I'm in the Office for the Advancement of Telehealth at the Health Resources and Services Administration. And I'd like to just take the time to welcome you to the CMS Reimbursement Successes and Lessons Learned from COVID-19 session. So for our session today, I will be facilitating a discussion between three panelists who are currently addressing this topic within their fields of expertise. And I would just like to take a moment to give each panelist an opportunity to briefly introduce themselves. So I would first like to start with Katrina Lewis.
Hi, everyone. As she said, I'm Katrina Lewis, and I currently serve as the Audit and Education Manager for Kiwi Tech, and we're a coding consulting business, dealing with coding, auditing, education, all of that through at various facilities throughout the U.S. And then I think we're turning it over to TJ.
Sure. My name is TJ Ferrante. I'm a healthcare attorney with the law firm Foley and Lardner. And my practice focuses primarily on working with healthcare industry clients and helping them build out and operate digital health arrangements in various models across the country, multi-state models most likely. And a lot of our clients are very large and sophisticated hospitals, academic medical centers, health systems. But we also work with a number of smaller, yet still very innovative and disruptive startup or early stage type of companies as well to build out those new and exciting models using healthcare technology to scale nationally. So happy to be here.
Yeah, hi everyone, I'm Emily Yoder. I am an analyst in the Centers for Medicare. I work primarily on physician payment and specifically physician payment for Medicare telehealth services. So I've been very involved in CMS's sort of expansion of Medicare telehealth, and I'm really excited to be here and speak about that with you all today.
Great, thank you to our panelists for the introductions. For the participants, you can find more information about each of the speakers in the Event Mobi app under this breakout session, or just if you also go to speakers within that app. And so before we just start our discussion, I would just like to share some logistic information. If you have questions for the speakers or presenters, we will have a time at the end of the discussion. So we ask that you please type your questions into the Ask a Question feature for this session. That's found in the Event Mobi app on the virtual platform. And just at the very bottom of the session description, you'll find the box that has Ask a Question. If you're unable to do that, there is also the option that you can put your question in the chat box. With the Ask a Question feature in the virtual platform, if there's a question that's already been typed and asked, and you're also interested in information on that question, you can please just click the arrow next to the question, and that will upvote your question. So at the end, when it is time for Q&A, we will be sure to start with the upvoted questions and make sure that those are addressed first. All right, so I'm excited to get into our discussion now with our panel. And I just would like to start off our discussion this morning and ask if someone would be able to explain what is the difference between telehealth and other virtual care services like remote patient monitoring.
Sure, this is TJ. I can field that, and then the others can supplement or comment what they feel. I know the title of this is a little bit to talk about some of the successes with telehealth, and particularly the reimbursement by Medicare. And so there is an important difference or distinction between telehealth and these other services, virtual care services, more than just the vernacular, because it affects the payment as well. So as most people probably on this call understand already, that difference does exist, but that Medicare does pay for quote unquote telehealth services as a defined term. But to receive that payment, there is a set of statutory sort of requirements or restrictions that have to be met in order for a provider to be able to receive that type of payment from the Medicare, at least the fee-for-service program. Most of these are statutory restrictions. So while CMS has certain flexibilities to promulgate and revise rules, a number of these, if they are going to get modified, would require congressional change or action. And these are the common barriers that if you are involved in the industry, you've likely heard before, namely that the Medicare beneficiary or the patient has to be located in a qualifying rural area, or has to be in an originating site. So typically like a healthcare facility, like a SNF, hospital, or physician office. Most of the time, they won't be able to get paid if the Medicare patient's in his or her own home. And then also for Medicare fee-for-service purposes, the technology is also dictated that it must be real-time audio video. So the Zoom call, for example, or a video visit with your provider would have to be utilized, and other type of technologies, although there are very limited pilot programs, wouldn't be allowed. But what happened, and it's really fairly recently, just the last few years, is the agency has come out with a new concept of these communication technology-based services, and those use non-face-to-face type of technologies, right? So you don't always inherently are going to hear and see the doctor and the patient at the same time. And because that the technology is always going to be used, it's definitionally just inherently different than what the historical or traditional definition of telehealth is, at least from Medicare's perspective. And because it's something that's inherently different, I think the argument is that it can be modified differently, right? If it's not telehealth, then CMS can take the position that it is something different and has the jurisdiction and authority to then promulgate rules and payment associated with those type of services. And these are like things like virtual check-ins, remote evaluation of pre-recorded data, your interprofessional consults, some of the other care management services codes like chronic care management, transitional care management, and probably what we've seen very commonly used now is remote patient monitoring. Again, all of these are, definitionally different, and so they get paid differently. They have different requirements. They don't necessarily have to meet all of those draconian location or technology type restrictions of your traditional telehealth. And again, this is all before the COVID sort of waivers, which have allowed a lot of flexibility in all instances of the virtual care modalities. But I do think there's going to be a place for these video visits in the future, regardless of the pandemic. So I think it's going to be exciting to see how those play a role as well in the overall service offerings. But I'll let Katrina or Emily, if you have anything to add on that.
Yeah, I mean, I think that you did a great job of summarizing Medicare's policies. I think Medicare has always, we've sort of taken the position that the statute specifies that Medicare telehealth services are services that would normally have been furnished in person. And so basically what we do is we take in-person services and we add those to the telehealth list, indicating that in certain circumstances, provided that all of the restrictions that TJ mentioned are met, that service is like an in-person service. The difference and the distinction between something like RPM or the virtual check-in is that they're not actually in-person services. There's nothing inherently in person about RPM or the virtual check-in. And so the way that we've sort of read the law is that in those instances, because it's not a substitute for an in-person service, it's its own distinct service, that the statutory restrictions in 1834M do not apply in those instances. And so that's how we've been able to pay for things like RPM or the other communication technology-based services.
And this is Katrina. Again, you both did a great job of explaining all that stuff that I don't have to explain now, right? But I did want to address just one thing, because from the coding and reimbursement side, we oftentimes get people interchanging those terms, telehealth and telemedicine. And to go a step further, I mean, of course, in this call, we're discussing CMS, but to add to it, sometimes our various commercial payers or even our state Medicaids might use the terms differently. So I think it's really important that whenever we're talking about telehealth or telemedicine, in our organizations, that we make sure and define exactly what it is we're talking about, and that we look at not only what CMS is saying, but also our top payers that are paying us, what they're saying when we're coming up with all these definitions, and when we're coming up with, you know, how we're going to capture these different services.
Great, thank you all for just kind of sharing that information and how it affects the different sectors that you all come from and work with. So that gives us a good background of just kind of understanding telehealth, telemedicine, and remote patient monitoring. So TJ, you had spoke a little bit, referenced that expansions are being made during this public health emergency, and with those implementations, it has allowed for some flexibility to be able to provide telehealth services to meet the needs in healthcare. And so what has been the public response to some of the expansions for telehealth during this public health emergency?
Yeah, so I can actually start, and others, again, should certainly chime in, but we've really, the public response has really been sort of overwhelmingly positive. I think that many of these changes, particularly the ones that we accomplished through the waiver authority, which was sort of allowed us to remove a lot of those restrictions on like where the patient has to be and the technology in certain instances that can be used to provide telehealth services. That has been something that people have been asking us to do for years and years and years. And so when we had, you know, sort of with the waiver authority, we were able to do that, and the response has been really, really, really positive. Of course, sort of folks are concerned about what will happen sort of at the end of the PHE, but right now, the sense that we get at the agency is that people are really taking advantage of these expansions in a way to sort of protect Medicare beneficiaries from unnecessary exposure and to, you know, to help with providing care during this pandemic.
And so, Emily, would you like to explain just a little bit more about what some of those changes to the Medicare telehealth have been in response to the COVID-19 pandemic?
Yeah, absolutely. So there's sort of two kind of buckets of responses. There is the responses that we were able to do through waiver authority, and then also what we were able to accomplish through just regulatory action. So the restrictions on geography, location of the beneficiary, type of practitioner who can provide a Medicare telehealth service, and the technology are all in the statute. So what Congress did most expansively with the CARES Act is give CMS the ability to sort of waive as much of 1834M as we wanted. So we waived, over the course of several months, we were able to waive the geographic restrictions, the site of service restrictions, again, restrictions on practitioner type. And then we were also able to allow for audio-only telecommunications technology for certain behavioral health, counseling, and educational services. So essentially what this did was it allowed beneficiaries to receive services in their home, and also for beneficiaries in urban areas to receive services remotely. And so then as a companion piece to that, we actually took a look at our regulations and went through and sort of tried to identify all of the regulatory hurdles that have been sort of put in place over the years so that we could really get the federal government out of the way of practitioners in terms of how they choose to furnish care to beneficiaries utilizing telecommunications technology. So this included adding over 100 services to the Medicare telehealth list. That's the list of, as I'm sure you all are aware, of services that can be furnished as telehealth services. So I think that was probably one of the most significant things that we've done. But then we also removed things like frequency limitations. There were limitations, for example, on how often a beneficiary residing in a nursing facility could receive a telehealth visit. It was once every 30 days. We removed all of those. We provided clarity around sort of for our communication technology-based services. We said these can be, normally they would only be billed for established patients. We said they could be provided to new patients. Just really trying to identify and remove all of those sort of regulatory hurdles.
I just wanted to just add one thing, or just make an observation in the various, throughout the months, that went on. CMS held a variety of calls. They held office hours calls. They held stakeholder calls. And one of the things that I noticed from that is that a lot of the information that was brought up in those calls, I did later see come out with clarification and things like that. So just with us working in this field, I just wanted to add that it was awesome that CMS did that. And I think that it's important that whenever we have changes or anything like that, that we take advantage of that so that we can make our voices heard. Because again, I did see a lot of those things later updated in the guidance.
Yeah, and I was just building on that. I mean, going back to sort of what the response from the community has been. I mean, it is felt at many times more like a sort of a collaborative process because, as Katrina mentioned, we had all of those calls, all of those opportunities for people to provide us with information and sort of make requests for clarification that we could later sort of provide. It's really felt very like as I said, like a collaborative process and not so much like a establishing regulations from on high sort of a process.
No, that's great to hear you share what changes have been made, but also Katrina, the response that has been made versus hearing the voices on the ground. And so with that, with the changes that have been made and responding to the need and the voices on the ground, what types of services have you seen that are commonly being furnished as telehealth as a result of COVID-19 and the public health emergency?
Yeah, so what we've seen so far, and I want to caveat this really intensely because this is based on sort of an initial review of claims data, and claims data, like practitioners have a year to submit claims. So what we're looking at is very preliminary sort of snapshot. But what we're seeing actually in terms of the types of services, it's actually very similar to what it was pre-public health emergency. It's primarily office visits and it's and also mental health services. So let me pull up my numbers here. So office visits, they since the start of the PHE, nearly 5.8 million beneficiaries have received one of these as a telehealth service since the beginning of the PHE, which is just remarkable in terms of the overall utilization. But it also is, again, office visits are 25% of the physician fee schedule. So already that tracks with sort of the pre-public health emergency utilization. Also, 460,000 beneficiaries have received the telehealth mental health treatment. And again, through from a psychologist or a psychiatrist. And again, that is consistent with what we've heard about telehealth outside of the public health emergency, that it really is frequently used for the provision of mental health services.
I got a question, not to put you on the spot, Emily, but do you happen to have similar information for the other type of services that are not quote unquote telehealth, maybe RPM or the other virtual care codes by any chance?
Not at the tip of my fingers. No, I'm sorry. We're still, so the utilization for those services is still fairly low, which is what kind of consistent with what happens when we sort of set out new kinds of services. Practitioners are still trying to figure out how to bill, under what circumstances they should bill. And so we sort of anticipated even several years ago that utilization uptick will be slower, but we hope too that the sort of experiences through this public health emergency, that something positive that could come out of that is that maybe practitioners now are much more comfortable using things like doing services like RPM or the virtual check-ins or the remote asynchronous service.
Great, and thinking about billing and what claims to use, and especially for offices and healthcare providers where telehealth is something they've heard of, but putting into action came very quick with the public health emergency. When providers are thinking about billing and claiming for appointments, what place of service should be used on a claim when a visit is conducted through telemedicine?
So I can take that one. Well, again, when we're talking CMS, and the understanding is whatever place of service that you would have typically received that service in, that's what you would do. So for example, if you typically would have gone to the physician's office, I think that's what place of a service 11 or something like that. So that's what you would use there. When we talk about, lessons learned and things like that, what I found is that many of our large, commercial payers have followed suit with that. But it is important that if you're dealing with any, some other commercial payer, that if they follow a different guideline, like maybe they want place of service 02, then you'll want to be mindful of that. A lot of these things can be addressed like from a system standpoint. So depending on what practice management system you have or claim software you have, it can look for maybe 2 points, like maybe if you've got place of service this and modifier 95, the two of that together for this payer that doesn't want the place of service for the physician's office, the system will automatically flip it to 02. So there's different things that you can do on your end if you are dealing with a payer that does not want the place of service that describes the place where the service would have normally taken place at.
Great. And with the modifiers, is there a certain modifier that we should use GT as opposed to using modifier 95 when it comes to telemedicine?
So this is another one, that at one point for certain payers, we weren't using a modifier because we had that place of service 02. But the thing is, right now we're using modifier 95 mostly. Okay, but you do want to keep in mind that, of course, some of your state Medicaids will want modifier GT. We've got some commercial payers that are saying you can report either modifier 95 or modifier GT, and either way the claim will go through. But for the most part, we're seeing modifier 95 specifically for these telehealth services that utilize real-time audio and video telecommunications. I don't know if Emily wants to maybe speak to some of the other ones, because I've heard different things about like the telephone services, but for the specifically for the real-time audio and video telecommunications, we're primarily going to be using modifier 95, with the understanding that some of your other payers might want modifier GT, or they may accept either modifier.
Yeah, so in terms of audio only services, we actually don't have any different requirements than just for the rest of telehealth. It's the place of service where it would have been had it occurred in person, with the 95 modifier to identify it as telehealth. So there's actually there's not a separate requirement there. But I think that you've done a really good job of laying out sort of the case for why like clear guidance is needed, because it can be so confusing to have different sets of requirements for the claim for across different payers. And so I just wanted to sort of highlight that point because I think it's really important.
Great. And continuing to just talk about claims specifically when we're talking about COVID-19 and determining how would a site be determined when the diagnosis of COVID-19 is given. Should that be reported first or secondary on the claim?
Well, really, it's going to depend on the circumstances of that encounter. So, of course, yeah, there's all sorts of myths and things going around. I've seen them on social media where people say everything gets a COVID code. It does not, we really have to look at the circumstances of the encounter. Now, if COVID-19 was an established diagnosis, not suspected, not possible, not probable, but confirmed diagnosis, then of course it should be reported on the claim, and that's no different with any other diagnosis code when we talk about confirmed things. But if it was the reason chiefly responsible for the services provided on the outpatient side, or on the inpatient side, it was the chief or primary reason that occasioned that stay in the hospital, then it should be reported first. If it is a confirmed case and it does not meet either of those two definitions, then it would be reported as a secondary code on the claim. And I always recommend that then be reported within like that 2 through 4 range. But that's just a Katrina thing. That's not, that's not a requirement, but you probably want to see it closer to the top, considering we are in the PHE, but you just really want it secondary if it does not meet the reason chiefly responsible for the services provided, or on the inpatient side, the reason that chiefly occasioned that stay. I also wanted to touch on another piece that, at least from the coding side, it's taken a lot to get coders to understand this and to do this. We're typically told in our coding guidance, we get it from the American Hospital Association, CDC puts out guidelines and things like that. And typically we cannot code from a lab report. So with this PHE and everything, the guidance that we receive from the American Hospital Association, as well as the CDC, is that if we have a patient that was tested for COVID-19 and the test results are not back by the time that patient is discharged, we are allowed, and it's actually recommended, that we wait to code the encounter or submit the claim until after that lab has come back, because we are actually allowed to assign that diagnosis based on the lab. Now, that is not something that's typically done in coding. This is something, it's unprecedented times. We got to do some unprecedented things. And I think it's a good thing, because I think it allows us to really be able to capture this, because otherwise, how would we really know for ourselves, when we're running our own data and getting our own numbers, how would we really know the number of positive cases if we weren't capturing it somewhere?
Great. No, thank you for that information, but also for that insight, advice from your experiences with coding and specifically when it comes to the COVID-19 diagnosis. And so billing and reimbursement is something that we're definitely seeing within the healthcare establishments that are affecting telehealth and have been changing throughout this public health emergency. But another common area that gets some questions is around licensure, and telehealth appointments have offered an increase in access to care beyond just local care and even into cross state lines. And so there is some question, and I would like if you all could give some clarification, but do multi-state license issues still arise in remote patient monitoring or other non-telehealth service models?
Yeah, this is TJ. I can handle that one. So the short answer is yes. There is that underlying concept that I think most of us are familiar with regard to a multi-state virtual care practice. And that concept is essentially that clinical provider has to be licensed in the state where the patient's located at the time of the virtual care encounter. And so that doesn't only apply to your traditional or historical Medicare fee-for-service telehealth. It's really a state requirement in addition to the Medicare requirements, and it applies to, or can apply to, various other type of technologies. So, for example, if you have a remote patient monitor vendor type of business model where a clinical care team is remotely monitoring a patient, and members of that team are interacting with that patient, providing advice, et cetera. Those clinical care personnel, they should have or be appropriately licensed where that patient is. That goes for other asynchronous models where you have a doctor or another provider type that's reviewing maybe some information questionnaire images, medical charts, et cetera, for a particular patient, and based on the review of that clinical information, if they render an order for a prescription for a drug or an order for some sort of other device, that doctor has to be or should be licensed in the state where the patient is located. And so again, that's the general rule across the different technology types. And really, it transcends your payer source. So while Medicare has general licensing requirements as part of its reimbursement conditions, there are state laws. And right now, we've seen waivers that Emily talked about, and some of those include the requirements for a doctor or a clinical provider to be licensed or have a license in another state. Which is great, and it has added a lot of flexibility from a reimbursement perspective. But then you also have to look at your state laws, and those have not changed as uniformly as potentially we might have wanted or needed during the pandemic. It's really been sort of a haphazard or approach, and different states have had different reactions. So, for example, here in Florida, we do have a pretty broad a licensure sort of waiver that's passed to practice here in the state of Florida. So if you're an out-of-state healthcare practitioner and you have a license in another state and you're in good standing and all of that, you can't provide services to a patient located here in Florida without having a Florida medical license, for example, if you're using telehealth. And not all states, again, have this, so you do want to be careful. I know it was particularly in the months previous to our presentation here today, such a big push to just provide care, and there was so much flexibility in the rules. I think sometimes people did forget or didn't quite understand what the rules were for where and when, et cetera. And while there might not be an extreme risk of enforcement or exposure for your healthcare providers, there could be some, particularly in sort of, events that we all hope don't happen, but statistically will. And that's if, patient harm occurs, right? If a patient gets hurt or sick, and it's a result of some sort of arrangement where you as a doctor or healthcare system or provider aren't in compliance with the law, then those plaintiff attorneys, they start to salivate on those type of issues. And so as a risk mitigation strategy, you do want to make sure that you're taking into consideration not only your federal laws, your payer source requirements, but also the state by state requirements. And that's does heavily involve licensing.
Great. And in talking about regulations and laws too, another hot topic when it comes to telehealth is prescribing and regulations surrounding that. And so with this public health emergency, some people have heard that prescribing based on questionnaires is unlawful, but we also know that physicians are prescribing without seeing a patient in person, even virtually. May you explain a little bit how that might be possible?
Yeah, so for that, so a number of states, a lot of states actually do, they expressly prohibit what's known as internet prescribing based only on like a static questionnaire. And the actual definition of what that means can, internet prescribing can vary state by state. But it's really, most commonly it's defined as, prescribing drugs to an individual and the physician has never met that individual, and it's based solely on this sort of patient's response to a couple questions, right? I've seen some extreme examples, for example, where you go online and you fill out your gender and maybe your credit card information, and then they're going to ship you a drug, right? Those are the type of arrangements that the DEA and other state agencies have really been trying to prohibit and stop, because that's not good medicine. That's what these laws are getting at, is clinically insufficient or substandard ways to obtain information from a patient and then just kind of render a prescription really mostly financially motivated rather than clinically intended or motivated. But that's very different. And a lot of these rules, by the way, are fairly old. Most of them, went into effect in the 80s and 90s when it was really a push to kind of attack this drug diversion or fraudulent prescribing type of schemes. And so a lot of these haven't really contemplated, or weren't, when they were created or passed, didn't really have the future understanding of what the world is today with the different types of technologies and the way that care can be rendered now in a safe and appropriate manner. So, that's different than, today we do have legitimate, I believe, legitimate asynchronous clinical workflows where, there are a combination of tools, including dynamic questionnaires that can essentially be modeled after what an actual in-person, interaction with the doctor would be, right? That Q&A. And that's where, if you talk to a lot of primary care or other on the ground physicians, that's where they get a lot of their information, including in with that other extrinsic medical information, like a patient medical history or chart, other images. We now have home diagnostic tools and the like that can be used. So, I do think there's, we want to be cautious to be aware of those companies out there that are not doing it right. But there's definitely a place for, I think, clinically appropriate asynchronous approaches to delivering healthcare.
Great, thank you for updating us on that information. And so we've spoken a bit here about CMS and coding and reimbursement within CMS, but outside of Medicare, I'm sure we have some participants here where they are seeing patients that do have other insurance options. And so outside of Medicare, what would be the best way to assess if an insurer will pay for telehealth?
Yeah, so I can jump in real quickly on that one again. My advice would be the first place to start to look is to see whether the state that you're looking to provide healthcare services in is a state that has a commercial payer law on its books. So most of the states have one now. There's I think it's around 42 states, and then DC has one too, I believe, that have some commercial payer law on the book. Now the rub is that these laws can really vary quite drastically in what they actually say and what they actually do. So when I talk about commercial insurance laws, there's really two concepts to keep in mind. One is sort of the coverage law, and basically that would say something like, hey, health plan, if you're going to provide services in person, you have to provide the same service if it's delivered via telehealth. You provide coverage for that service as well. And that's a contract between the individual health plan and sort of providers. It's kind of a B2B relationship, and it talks about, it's members, and it's more of a direct-to-consumer relationship because it talks about access to care for members. The second concept is more of the B2B relationship. That's payment parity. So that's what a health plan is going to pay the doctor. And we have seen, instances where, particularly if the commercial payer law doesn't address it, where you have a law that says, hey, health plan, you have to cover it, but we're going to be silent on what you have to pay for it. And we've seen, New York was an example several years ago where they came back and a lot of the health plans were paying like 50% of that fee schedule that they would pay in person. And the arguments are, at least that I've heard on the provider side, would be that, is my delivery of care worth less, or why, how does this even cover my cost of the clinical staff, et cetera. So that also, it can be a friction point for being able, from a business modeling perspective, launching into areas of reimbursement. So you want to do coverage and parity. And most of, again, the states have that coverage requirement. Fewer, I think it's maybe 16 or so, maybe even less, have the payment parity about how much they pay. So that would be, I think, the first place to look, because a good payment law can serve as some teeth to get the health plans moving. The ones that are a little bit more vague or ambiguously drafted, we've seen them use health plans, that is, escape hatches, to say, well, we don't have to cover it. And then you're left with trying to really advocate on a one-off basis to get your particular program off the ground and paid for.
Great, thank you for that information. Just want to begin to wrap up our discussion, but Emily, I would like to ask you if you could just share probably some information that's burning on a lot of the participants' mind, is what will happen to Medicare telehealth at the end of the pandemic and the public health emergency.
Yeah, that certainly is the million-dollar question right now. So some of the flexibilities, the ones that we did through waivers, again, that's the geographic site of service, practitioner and technology restrictions, all of those are in the statute. And so in order for those to be modified or removed, that would require an act of Congress. In terms of the things that that CMS has regulatory authority over, we have been sort of internally we've been in the process of sort of trying to identify which of the flexibilities that we put in place for the public health emergency do we actually want to adopt on a permanent basis. So were we to choose to propose to adopt some of those changes, it would appear in the physician fee schedule notice of proposed rulemaking, which is historically published in mid-July, which we are at. So hopefully it will be out soon. And because that is where we do the rulemaking that is associated with Medicare telehealth, and that is where we would make our proposals. And there's a 60-day public comment period, and we really, really, really would encourage folks to comment on that rule and to provide us with sort of information about how they've used these flexibilities during the public health emergency, and really speak to their experiences and what would be helpful to have on a permanent basis.
Okay, great. We will keep our eyes open as we begin to continue throughout this month, and updates and things become available. And so before I open it up to our questions from participants, I do want to remind participants that you can use the app, ask a question, as well as put questions in the chat. But I would like to offer the opportunity for the panel to give any last comments on successes or maybe some top lesson learned from COVID-19 and reimbursement.
So I guess I can start. So from sort of my own personal perspective, it's been really remarkable to be in this policy space right now. We have heard for so long that Medicare has really lagged behind, particularly commercial payers, when it comes to sort of recognizing the role that technology has in healthcare. And so it has been really sort of a remarkable experience to kind of be able to see what would happen if we sort of were able to throw open the doors and more broadly sort of pay for services that utilize telecommunications technology. I mean, we have done like 20 years of policy making in 4 months. And that's been a really like interesting experience. And so, and it's also, I feel has made me sort of hopeful for how Medicare sort of making steps towards continuing to modernize payment for services that utilize telecommunications technology going forward.
Thanks, Emily. From my standpoint, I think when we just talk about lessons learned specifically on my side of the house, coding, billing, reimbursement, things like that, from a consultant's standpoint, is that you really have to stay up to date with all of the different changes. You know, it's one of those things where, you know, maybe, of course, once a year we would deal with CPT changes. Once a year we deal with ICD-10 changes. Of course, we've got CPT assistants scattered in there, coding clinics scattered in there. But, you know, a lot of, if you were entry level at the coding level, you probably weren't reviewing those things. You probably only had to deal with changes twice a year. But what it's taught me is that our career field is very resilient, and that we really have been able to adjust to changes, not just with coding in general, but with various payers, and understanding our role with technology as well. So, you know, a lot of what we do, of course, is on the computer, and you think about that, you know, we're entering codes and systems and things like that. But what I've realized over these past several months is that our voices were able to be heard when it came to things specifically with the technology, setting up electronic health records to capture data that wasn't being captured before, showing coders who previously would not have had to look at a lab where they needed to go, and putting, time frames or waiting periods between submitting claims, as well as making recommendations on things like I talked about before, where, hey, if you've got this payer here and you see this modifier in this place of service, the coder doesn't have to remember 20 different payers' guidelines. Put a system, check in place to automatically flip it to the correct modifier for that payer, or to flip it to the correct place of service for that payer. And so I'm just excited for all the things that we've learned that we're going to be able to take into the future.
And I'll say, one, thanks both to Emily and Katrina. I appreciate those comments. I think they're spot on. The one thing I'll say is, and I think to start with, it was a quote, I can't remember, I think it was Abe Lincoln, and I'll butcher the quote, but something to the effect of, if you want to know what the future is, create it, right? This time is I think a crucial time for the industry, and probably is experiencing more momentum than it has maybe since its birth, right? And as Emily stated, CMS has taken, I think, a very forward-thinking position. But for us to, I think, have real meaningful change in the industry, it does require Congress to make some changes. And so right now is the time, if you are with an organization, or if you are, even if not, if you are a physician office or just someone interested, do please contact your representatives and make your voice heard, because this is where we want to use that forward momentum and really see if we can push Congress in a bipartisan manner to put something through that will, I think, make some of the historical barriers that have been in place for the last few years on telehealth more flexible, namely the originating site restrictions, the rural area restrictions. I think those are the big ones that we're hoping that will be changed, and I think that will be an extraordinary win for the industry and for patients, really, to be able to utilize that. I think the appetite's right now, so that would be my takeaway for the folks or attendees. And then in the meantime, though, because I deal with a lot of clients that are doing this, there's a great opportunity right now, given the flexibilities, for sure, and I encourage all to use that to help not only your patients, but also your businesses. But remember, these are all drafted both on the state level and federal to sunset. And so if there isn't that permanent change, do understand that your business models will also then have to adapt again and change. And we're not really sure how it's going to end, right? The way these are drafted, it could be a cliff. And hopefully that's not the case, but a lot of these are tied to the end of the public health emergency. And the way the public health emergencies work is they're in effect for about 90-day increments, but they can be terminated basically at any time if there is deemed to be no longer a public health emergency. And there's no requirement that the agency has to give notice whether or not it will renew. We're actually coming up on a renewal on July 25th. I don't know if Emily's seen it. I haven't actually seen a formal announcement that it's extended. The industry is really hanging on. There's been some comments, and there was actually a tweet, that's the world we live in now, from a representative from HHS that said that it would be extended. So I think we all are operating that it will be, but the formal extension, I think, to come. But that would be my last bit of advice, is to keep in the back of your minds that these flexibilities do have different sunset terms. Some are different time periods based on state law and federal. So do keep your eye on the ball there, because you could, if you take it off the ball, you might end up in an area where you're not compliant and you don't even really realize it. So.
Thank you very much to each of the panelists for answering some of these questions that we're hearing and organizations are wanting to know, and giving us insight to some of the concerns that are on the ground around CMS and reimbursement, and sharing the lessons that you have learned from each of your respective fields. And I would like to now just turn over and take the opportunity for Danielle, if you will lead us with any questions that have come in.
Sure, we do have a couple. Thanks so much, all. That was excellent. And I know that you can't, it's been such an evolving landscape, right? It's hard to possibly cover it all, or impossible to possibly cover it all. We have two very related questions, so I'm going to try to synopsize them, and then each of you can respond as relevant. What, if any, efforts are being pursued toward the uninsured and underserved post-COVID, now that it's been demonstrated how this population affects community health, as well as their rights of being healthy regardless of socioeconomics?
Yeah, I'll take a stab at it. I'm not sure if I'm the actual expert in this area, but I think the closest thing that I've seen for underinsured or low income sort of patients or beneficiaries is really in the state by state Medicaid programs. So that's where we've seen some quite a bit of activity. And again, this really heavily depends on where you are, because as you all know, certainly my co-panelists know, and likely those on the call today, is that states have different ways to approach their Medicaid programs. Some are fee for service still, some are more capitated, and then all of the policies that go with it. I would say, generally speaking, we've seen a very significant trend on much more forward-thinking from Medicaid agencies with respect to the type in ways they deliver health care. So even sometimes more so than the Medicare program, in the sense that they are allowing some of these different technology types. They are eliminating some of the barriers of certain consents or co-payments or things like that, to really try to push through the ability for a Medicaid patient to get care virtually if necessary, particularly given that in low income or in chronic condition type of families or beneficiaries, that travel and transportation is a real big issue. And you also mentioned in the question mental health. Those are big issues that plague a lot of these type of communities. And so I don't have like an answer as far as like what a particular state is doing, but the trend, I would say, and if you step back and look at all 50 states, has been I think in a positive way. A free resource is, and I think everyone here on my co-panelists are familiar with, is the CCHP. They do a great job of kind of tracking a lot of the legislative policy from a Medicaid perspective out there. And so you can, and it's free to go look at. So you can see kind of what and I think every year they even give like states grades on how their policies are. So you can kind of take a look at how states are doing and what their approach is to incorporating telehealth into their state programs.
Emily or Katrina, do you have anything to add to that specific question?
No, I mean, I think I want to sort of co-sign everything that TJ said and echo the CCHP is a great resource for a number of issues pertaining to telehealth.
I will say from our Northeast Telehealth Resource Center, we have seen some real innovation within our federally qualified and rural health centers, looking at healthcare reform, utilization of digital health, telehealth to address social determinants of health. So it's more outside the traditional reimbursement mechanisms. So they see the return on investment for offering Medicaid signups, for referrals to WIC and other programs for underinsured and uninsured folks. So they might not be receiving traditional reimbursement, but they might be able to get quality dollars because they are able to better reach and provide access to these services. Parolees, I mean, there's just some true innovation going on within these health centers, and we're proud and happy to be a part of it. But so those are some of the innovative types of things that are going on outside of traditional reimbursement, where some of the limitations still exist. So I would say, think outside the box and contact your telehealth resource center, and we're always happy to share some of these resources and ideas for business models and et cetera. Thank you, Whitney, for sharing the CCHP website there for many, many awesome resources. So I also wanted to, Carlos had brought up the recent health affairs publication written by Administrator Seema Verma noted that over 9 million Medicare beneficiaries received FFS or fee-for-service telehealth services during this pandemic. That's pretty amazing, and we're seeing similar across private payers and Medicaid programs. This is a loaded question. Do you expect that number to double or triple by the end of this year?
So I'm going to put on my bureaucrat hat and say I can't really speak to that, unfortunately. I don't know if either of my co-panelists have anything they could share in that regard.
Before I answer that, I just wanted to take a step back to the question previous, if that's okay. Because I think, we talk about Medicaid and all of that, and, that's going to be great for when we talk about some of our uninsured. But I'm hopeful that we'll see some additional things for patients who are uninsured or underinsured, but they don't qualify for Medicaid, like they're, like that working poor that we talk about. So I just wanted to slide that in there because, we know, of course, that not everyone who is uninsured is a person that doesn't want insurance. Sometimes it's that they don't qualify for things and they can't afford the insurance. So I'm hopeful that we're going to see some additional things outside of that. But for, for this question, do we expect to see increase? Can I say an exact or definite yes or no? Of course I can. I don't think any of us have a crystal ball. I would imagine that there will be. I mean, we've seen numbers going up, I'm thinking most of us probably watch the news or look at the numbers and things. So I would imagine that we'll probably see an increase. I can tell you specifically just in my family, not just in my home, but my extended family. That's how we're getting seen these days.
Yeah, and I agree. I mean, doubling and tripling, those are very ambitious figures for sure. But I'll say, I think the answer is yes to all of them. It might be more of like, what's the timeline for that? I think we are on a path to get there with those type of numbers in our system, particularly if we talk about before, get more legislative sort of action to have your traditional telehealth made permanent, right? So I think if we move into that space where telehealth is now going to be paid for in a lot of these, in the patient's home, for example, that will certainly, I think, increase utilization for those services. I don't know. I haven't looked at the latest Congressional Budget Office reports. They've struggled over the years with trying to understand that, I think. So I don't think anyone really knows what the real cost will be necessarily or how many people will use it. My personal opinion is, and this is a little controversial, is I do think the technology is going or should be a lower cost. I mean, a lot of times we talk about payment parity, et cetera, but really, if you think from a very high level, what we're doing is we should be leveraging these tools to provide care in a better way, in a cheaper way. And so I think over time, I think it should justify, the cost of the care and thus maybe the reimbursement if we are still in a fee-for-service model to adjust accordingly. So that I think it goes to the underinsured component as well, is that the more competition, the more technological advances we have in space, hopefully even for a self-pay, some of these self-pay companies are going to get to a price point where your normal working underinsured person is able to come out of pocket $10, $5. I don't know what the prices could get down to, and get their health care that way, even outside of the other traditional insurance markets.
Right. So guys, I think we've come to the end of any additional questions. I've actually gone ahead and allowed anybody who's still on here with us to talk. So if anyone would like to either raise their hand or unmute, you can go ahead and do so. We have about 3 minutes left for questions for our panelists. I see some folks on here who I know have questions. Several peeps from our region. Don't be shy.
Hello, this is Huda Eldasugi.
Hi there.
Hi, thank you for answering the question earlier. I wanted to know, what would you like to see in telehealth for the uninsured? Like, what technology would you like to see? What service would you like to see? If somebody's working on this, what would benefit that segment, please?
Mm-hmm. I think Katrina might have a response.
Well, I mean, what I would like to see, I just would like to see some other options, specifically when it relates to telehealth or telemedicine, virtual visits, things like that. Of course, we do see some private companies to where you can sign up and you can pay a certain dollar amount a month and you can be seen, or you can pay a small fee. So hopefully we'll see some more of that. That's my hope. Of course, things probably are not going to be free. I mean, it costs money to do things, but I just think making things more more available and at a hopefully a reasonable cost is what I would hope to see in the future.
And this is TJ. I think a part of that, particularly in lower income communities and also rural communities, is one of the barriers or one of the problems or friction points is connectivity, right? And so in rural areas, in low income, although many people do have access to Wi-Fi or an iPhone or a smartphone or something like that, not everyone does. And so being able to get the technological tools that are necessary into these people's hands, because you could have all this great technology, but if your patient can't get it or doesn't have it, it kind of stifles the ability of what technology or telehealth can do. And so, the FCC has received money through this recently through I think it was the CARES Act or one of the recent legislative passes, and a couple $100 million, $200 million or so, that's supposed to be earmarked for not-for-profits and to really help build out some infrastructure. There's been a push by the FCC for a while to really try to get broadband infrastructure built out in a lot of these communities so that it will help with that connectivity issue, so that that people can be in their home or in their local community and not have to travel just to get a telehealth visit, right? And so I think that's part of the piece of it. And what I'd like to see is those resources, both federally, state, and local, dedicated to do that. The hard part about this is, and this goes with any of the public agencies, particularly the local ones, is my understanding, and this isn't in every location, is that a lot of them are getting hit pretty hard because of the COVID-19 and the decrease in their budgets and tax revenue. And so it will be interesting to see how that might negatively affect some of these public health programs that are out there on a local level that might struggle with funding opportunities, which is unfortunate.
Yeah. Yep. So Whitney, we do have one more question, and I think I'm guessing this is Kathy Fulton from BPQHC, and I only say it'd be great if we can fit it in, because I know this has been a big question in our region for quite some time. Any insight into audio-only reimbursement, and is that going to hang around? I know, what a question to end on, right?
That one. So in terms of traditional Medicare telehealth, right now, and TJ mentioned this at the beginning of this session, the requirement is actually it is a statutory requirement for an interactive telecommunications system, and we've interpreted that as two-way audio video. So it is our sort of position that Congress would need to step in to provide clarity on sort of whether services can be furnished via audio only. I will say that within the past few years, CMS has made steps towards paying for some services that can be furnished using a traditional audio only phone. The virtual check-in is a great example, which is technological modality agnostic, provided that it's a synchronous interaction. So we definitely are aware that this is an issue, particularly for Medicare beneficiaries, and we continue to consider it, but for telehealth, we're sort of limited by the statute.
Thank you, Emily. Thank you, Danielle.
Thank you for that last question. And like Danielle said, it's definitely one that people are waiting to consider more information about. And so I just wanted to take a minute to thank the panel again for answering and being available to us this morning and taking the time out. I think some big takeaway that everybody expressed at the end is really just staying informed on these updates that are coming out, and reaching out to Congress in this time to be able to express what telehealth expansions, reimbursements, regulations look like, and that impact that it's having locally. And so continuing to also stay flexible with your business models as things are quickly changing, and being able to figure out ways to adapt at changes that may occur anytime. So thank you all again. Thank you everybody for joining in this session, and just want to remind you to log into the EventMobi app and complete our session feedback for this breakout session. This is the last breakout session time period for the day, but there is a virtual exhibit hall available from 1 to 2 during the app again. So thank everybody again. Thank you to the Northeast TRC and the Mid-Atlantic TRC for doing this virtual telehealth research conference. So everybody have a wonderful day. Bye.
Bye all. Thank you.